We have some practices that will be joining our organization mid-year. We are trying to understand what this means to us for MIPS reporting for the year they join. The practices are small compared to our whole group and will represent less than 70% of our total patient volume. So even if we don't get all of the data for the year they join us, we should be confident that they are not pulling us below the data completeness requirement. But we are confused by the apparent contradiction in Medicare's statement that we must account for 100% of our eligible patients. Can you explain this?
Great question, Kennedy. Most of you are aware that Medicare's data completeness requirement is 70% for 2023, goes up to 75% for 2024 and 2025, and proposed to go up to 80% for the 2026 performance year. But seeming to contradict the leniency of that requirement is Medicare's assertion that you have to account for 100% of your eligible patients. This is difficult for a lot of people. I'll try to help you make some sense of that. This apparent contradiction is resolved with firm division in your mind of numerator to denominator. The denominator is the count of the patient's visits or episodes of care that are eligible for a measure. Because the denominator can be a count of different things, Medicare calls the things that are counted eligible instances. A denominator is a count of eligible instances that could be patients, visits, or events, or something else, I suppose. These instances represent opportunities to provide care. Now, it's easier to count the instances or opportunities than it is to identify with clear and unambiguous data the care provided. Determining the denominator or the eligible instances is the first step in any quality reporting effort. Now, Medicare requires you to know what this total number is. It's only by having an accurate denominator count you can know when you or Medicare can know that you have fallen below the data completeness threshold. Denominator data primarily comes from claims records. The great thing about claims data, it is nearly universally available. It's been around long enough that it's a mature and stable data set with nearly universally accepted standards. Every practice generates insurance claims. Claims are relatively simple and standardized. Electronic claims were all designed to emulate Medicare's paper HCFA 1500 forms. They all include universally recognized data standards of ICD-10 diagnosis codes and CPT service codes. A healthcare claim nicely defines the existence of a patient-doctor relationship. In the claims are identified this doctor on this date saw this patient of this gender and this date of birth providing these services for these diagnoses. That data set is the foundation of or the denominator for every measure. Getting that data is not a trivial exercise, but it is generally achievable in nearly every practice of any size. There are at least 3 different ways to get the data, and part of our task at Mingle Health is to help you find the best way, given the unique strengths and weaknesses of your practice, to get the data from each of your practices. It should also help you to know that claims data from your practice management system is adequately standardized so that there are rarely any barriers to combining that data from multiple practices. Multiple practice management systems in one practice in the same year, or any other mixing or matching you need to do. Now that you know that the denominator is a count of eligible instances, the gold standard for the count comes from claims data, and Medicare wants you to be 100% accurate on the count. Let's talk about numerator data and data completeness. Numerator data is primarily clinical data. It answers the specific question, what happened to the patients, or in the visits, or in the episodes that represent our denominator? Did they get what they want them to get? Did they avoid complications? Numerator data is not as mature, standardized, or as available as claims data. The 3 big problems with clinical data are too much of our clinical data is in natural language form, not in structured or discrete elements that are accessible to a reporting infrastructure. Numerator specifications are not always optimized for a structured data set. We don't have solid standards for expressing commonly required quality measurement concepts. The project and process changes dramatically when you change EHR, even if you're changing to a new instance or version of the same EHR. Medicare gives you a little more leeway with the numerator. Enter the data completeness criteria. So in review, in reference to the requirement to report 100% of the patients, Medicare is referring to the denominator, which counts the patient's visitor episodes of care that a standard of care applies to. With a 100% requirement, they are saying that you must know who your patients are, even if you don't know what you did for them. In reference to the 70, 75, or 80% data completeness requirement, Medicare is referring to the numerator, which is the care provided found in the clinical data in the EHR or your paper chart if you're still on paper. Thanks, Kenadi.